as a medical student, your job, your role is to gather history, is to ask the questions, not to give the answers, which is confusing because you spent so much time giving the answers. I think that is why it's so confusing about M3 clinicals. For the past 2 years, attending teachers, UWorld questions have constantly been asking you questions. And so you're quickly supposed to have an answer. But the real world doesn't work like that. There's not always one right answer. And so it's hard when a patient asks you a question, you feel, or you may feel that you want to answer the question. You want to feel helpful. You want to feel knowledgeable. Unfortunately, that is seen poorly because we really don't know everything, even though we've been spending the past 2-3 years thinking like we do. Being a lot of our knowledge, intelligence is seen based on how well you answer the questions, how quickly you can answer the questions, if you answer it correctly. And when a patient asks you a question, not necessarily do you know the right answer, even though it might seem like you do. What are the most challenging parts of the M3 year? It's not the medicine or interacting with patients. What I'll be talking about are the unspoken rules, or also called the hidden curriculum, which includes the specific roles of the M3 students. My name is Dr. Moss. Today, I'll be going over the blog post, Navigating M3 Clinical Year, 10 Lessons Learned. You can see it on medpsychmoss.com. I will start with 10 lessons learned through my experience. Then I'll talk about my specific experience and challenges that I encountered. Now, granted, this was years ago, so things might have changed since I was an M3. I'm currently a psychiatry resident. I have M3 students that I mentor and also on rotation when as a resident, and from talking to them, it seems to be pretty similar. This experience was also specific to my medical school. Granted, every medical school is different on how they do clinicals, but a lot of these concepts, especially when we're talking about the hidden curriculum of medicine, seems to be pretty consistent and just part of the big system of medical education. So after I talk a little bit about my experience, and obviously I sometimes go beyond this blog post and start getting my own experience and little things that I remember, but you know how it goes. And then I'm going to be giving specific 10 rules for M3 students. So I hope this helps you if you're just starting M3 clinicals, or if you've already done a couple months and still feel a little lost. I really hope this helps you. So if at any point I say something that or you have any additional question, please put them because I want this to be helpful for you. Okay, starting with the 10 lessons learned. Lesson 1. At the start of interacting with every new resident or attending, one should ask what their expectations are. This includes what to ask and what to communicate with their patient. For example, some providers might want you to ask something specific to them as their specialty or just something that they're specifically interested in. That is one reason. Also, sometimes this includes timing. Sometimes they only want you to see a patient for 5 or 10 minutes. And as a medical student, it's really easy to do longer than that. So do shorter. Hope that helps. And then including provider rounds. Ask specifically if you should tell the patient the specific plan and next steps before speaking to the patient alone. Oh my goodness, I remember this. I had an example where I thought it was our job, since we talked in a group after we ran with the attending and the residents, I thought it would be helpful to go tell the patient what our plan was. Some attendings like that, but the majority do not like it. They like to make sure that they are with you or they're the ones telling the plan, because plans can change. Sometimes you misunderstood what they said, or sometimes by the time that you get back to the patient's room, or let's say an hour later, new results come in, which completely changes the plan. Also, since you're a medical student, you don't always understand all the medications, all the diseases, and sometimes they ask you, like the patient asks you questions that you don't know. And that's why it's important to ask the residents like how much they want to disclose. I remember I was in OB/GYN clinical rotation and I went into the patient room. They wanted to have birth control. And so I started doing what we were taught to do in OSCEs, where it's like, what type, like asking them questions about, in addition to just gathering history, I started educating them on every single type of birth control. And my attending really did not like it. She got very angry with me. And that's why I learned, oh, I should have asked her if she wanted me to educate the patient on different birth controls. Did she want me to just gather history? Did she want me to just be like, cool, you're here for birth control and go back? Because that's what she wanted. Now, if you're a resident or attending, please talk to medical students and tell them what you expect, even if they don't ask you, because they're constantly going in and out of different providers, different residents, and everyone has their own expectations. It's hard, and I wish I could obviously tell the attending, don't be upset if the medical student makes a mistake. That's what they're in for. They're here to learn. So yeah, I hope that helps. Thinking about surgery rotation, sometimes the residents don't want you to scrub in. So not all the times do the attendings want you to scrub in. Sometimes they just want you to observe. And it's very simple. If you ask beforehand, then you can find out what they want. Maybe they only want you to scrub in halfway through. You never know. And it's better to ask beforehand instead of them being upset with you after. Been there, done that, not fun. Okay, next we're going to talk about lesson 2. Each medical student is assigned specific patients, which means you do not interact with all the patients. This lesson I learned when I was in psychiatry inpatient, because I thought that when we did group rounds that we would all, I thought since we all go in a room, I thought we like all talk to patients. That was originally when I was at the beginning of my M3 year. And no, it's supposed to be only the medical student and the resident assigned. They're the only ones who can open their mouth. That includes if attending asks a question. They're the only ones who can talk to the patient, get a history on the patient, follow up with the patient. Now, thinking about it, okay, this is one, because it gets confusing. If you are the patient and suddenly you have 5 different doctors come in, medical students, it gets confusing. And if you've ever been in the hospital and they keep asking you the same question over and over, it gets annoying. Like thinking about it from a patient's perspective, it gets really annoying to be saying the same thing over and over and over and over. So that's one reason. Second reason, going back to being a med student, you don't know all the things yet. You don't know all the medicine yet, and you don't want to say anything that's wrong from the hospital perspective, something that someone can sue you for or the hospital for. So these are part of the reasons why they have so many rules, or unfortunately, like I said, this is a hidden curriculum. They don't actually tell you these things. You just have to find out through error, through practice and error. So hopefully that helps. We're only assigned a couple patients at a time. If another patient asks you for something, go figure out who's the medical student or the resident who's assigned to that patient. You can say, oh, I'm not your medical student, but I'll go find your doctor, or I'll go find the person that will know more information. Just like if a patient had a question that you don't know as a doctor, let's say you are, like me, a psychiatrist, and a patient asks you a question about their regular health care. I'm not, if we're on the general medical floors, I'm not their main, I'm their consult. So I'll say, I don't know. I will go talk to the person that is your main team to help you. That's why it's important to go check in. I do want to say, like, even if it seems nice that you're helping them, it's more nice if you help them understand what it means, it's more helpful if you connect them to the right patient. Even though you might think, oh, maybe I know the answer, or maybe I could help. I will give the example when I was, what was this? Internal medicine. There was a patient that needed transport. I think they were going to like a CT or something, and the transport team wasn't here yet. I was like, oh my God, I can help. I'm not doing anything. Like, I can help push a cart. I thought I was being helpful. I was not. Later got in trouble and yelled at by the attending. The residents were helpful and were like, oh yeah, look at how helpful you are. But I got in trouble. Why did I get in trouble? Because that is not my role. And we'll be talking about that a lot throughout. Is M3 clinicals is really hard because you're trying to figure out where is my role. And in the hospital, there are people that are paid to be transports. They know how to safely maneuver the carts and beds. So think about it from the safety perspective of, even if maybe you were a EMT or maybe you were a transport before, because this happens, still the hospital doesn't like it because you could hurt a patient, they could sue you, blah, blah, blah. Anyway, so that's a good reason why it's not helpful, and you think it is. So the overall for this second lesson is only focus on your patients that you are assigned to, only talk about your patients you're assigned to, only talk to the patients you're assigned to. Okay, let's see what else in regards to lesson 2. I really need to write, I think that's actually going to be one of my next articles I write. I was accepted as a Doximity fellow where I get to write articles. So I'm going to write on being seen as unprofessional. And that word is used a lot in a positive way and in the not positive way in medicine a lot. So this is like a sneak peek, but a lot of times when these invisible rules aren't followed, it is seen as unprofessional, and you can get an unprofessional write-up, which is really sad. That is used as a weapon instead of a teaching moment. So I'll talk about that later. Lesson number 3, having good time management. We talked about this in number 1, but I'm going to bring it up again. So you must have good time management through only talking with the patients in a set amount of time. Talking to patients longer is actually not seen as a positive thing, even though you would think it is, especially when you're early in your medical career. You think, oh, I'm trying to get more information, but it's not actually, it's not seen positively by the residents and attendings. And this is why. It's actually seen as not good time management. That's another word that unfortunately part of the hidden curriculum. And things that you learned in the OSCE of do the HPI, of ask the patient about every single review of system, ask the patient about every single new symptom they bring up. Even though we seem to be taught that for the OSCE, when we're in real patient situations, it clouds the patient time, so you don't have enough time with the patient. And when we're talking about in clinic, since clinics are scheduled, unfortunately, for only 10 or 15 minutes at a time, if you as a medical student take, let's say, 10 or 15 minutes, you just used up the entire patient time, and attendings sometimes get pretty upset because then they can't get to the patient and all their other patients keep getting pushed farther and farther behind. So this is where it jumps back to lesson 1 of ask the expectations, ask the attending, like, how long do you want me to spend with patients? What questions do you want? What should I prioritize? So hopefully that's helpful. One of the attendings that I worked with in family clinic said aim for 5 to 10 minutes if you're in the clinic, and 15 to 20 minutes if you're in the hospital. Now, obviously, that's not for every rotation, not for every attending. In psychiatry, we do get longer. Sometimes they expect like 30 minutes. And I think that's also helpful to going back to the expectations to see if the resident wants to see them with you. At first, I remember I felt a little bit awkward with having them watch me because I was like, oh, maybe they're judging me. But It actually helps as a resident because one, we can see how you interview. We can help if the patient has any additional questions. And three, sometimes the notes that the medical student writes do not even count, at least for billing purposes. And so it's hard for the resident because they have to wait till the medical student comes back and then they have to do it themselves. And so that's if the resident comes with you, the medical student, don't see it as a negative. See it as like a helpful thing that they're just trying to do their job so they can also write the note. Now, sometimes medical schools slash residencies are okay if like medical student writes a note and then resident addends it or edits it is another way to say it. And then we send it to the attendings. Now let's see that I set everything regards to time management. A good way to stay on track is to put a timer on your phone. So that means that you can put like a 5 or 10-minute timer. That sometimes helps. If it goes off, maybe you can even make a joke with the patient. Sorry, I only have 5 minutes. Thank you for spending 5 minutes with me. Or I want to help you, but I only have limited time before my resident comes in or before my attending comes in. So what is the most important thing you want to talk about today? That's some things that will help you stay on time, but also show the patient that you care about them, that you value your time, and it also helps them feel supported. Oh, this is also good to know. So if you're in the hospital, a lot of this is regards to pre-rounding. You can always go back in the afternoon and check in how the patient's doing or ask them more. A lot of residents like that because it shows initiative and shows that you remember that you still have a patient, which is important because a lot of times in the afternoon, we spend so much time doing notes. And the thing is, a lot of time has changed from the morning patients to like the afternoons because we've done lab orders by then. Maybe they received new medication. And so that's like a little bonus point that you can use as a medical student. You can always ask because we talked about before, hey, is it okay if I go ask the patient? Or is it okay if I go ask how they liked that new medicine or what they felt after lunch or if they've had a bowel movement yet? If you're on internal medicine, they ask that all the time. After surgery, had they passed gas? Have they urinated yet? So those are all simple questions that is gathering history. And I'm sure we're going to do that in the other lessons or maybe rules. You as a medical student, your job, your role is to gather history, is to ask the questions, not to give the answers, which is confusing because you spent so much time giving the answers. Maybe, you know what, as I'm saying that, I think that is why it's so confusing about M3 clinicals. For the past 2 years, attending teachers, UWorld questions have constantly been asking you questions. And so you're quickly supposed to have an answer. But the real world doesn't work like that. There's not always one right answer. And so it's hard when a patient asks you a question, you feel or you may feel that you want to answer the question. You want to feel helpful. You want to feel knowledgeable. Unfortunately, that is seen poorly because we really don't know everything, even though we've been spending the past 2-3 years thinking like we do. Being a lot of our knowledge, intelligence is seen based on how well you answer the questions, how quickly you can answer the questions, if you answer it correctly. And when a patient asks you a question, not necessarily do you know the right answer, even though it might seem like you do. There's always like little things in real life that maybe make it not 100%. I know that this is actually even a challenge that I deal with right now as a resident, since I've now spent 4-5 years working to answer the questions super fast and step 1, step 2, step 3. And so I want to give the answer or say, oh, based on these symptoms, the patient has this diagnosis. So for example, I had a patient come in that seemed in textbook like the first manic episode of bipolar. And I was so excited. And then I told my attending and resident, and they're like, we can't come to that diagnosis so quickly. And at first I felt very bad because I'm like, wait, does this mean that I don't know information? Does this mean I'm not intelligent enough? Do I not deserve to be in residency? But the thing is, in real life, in real clinic, we have to give patients more time to show symptoms. Everyone is allowed to show different symptoms at different times, and not all the time should we make the diagnosis right away. Sometimes it's helpful to see them over a couple of days, put them in patient, put them in the hospital, wait for lab values, make sure it's not something else. And that is one of the hard things about medical education. And no, see, I'm already giving a lot of like additional lessons from M3 instead of following with my blog post. Like, yes, when we're a student, we're supposed to give differentials to the healthcare provider, the attending or resident. And so that's important to do after you've seen the patient is say, look, I think it could be X, Y, or Z, and it's most likely X. And then as a resident, I think do the same thing. But instead of sticking to one answer, I'm supposed to say, but I'm going to do way more diagnosis, no more workup instead of just jumping on an answer. And that is hard. And it's something that I myself are still learning as a resident. So hopefully that helps you. So let's go to the next one. So lesson number 4. When we visit a patient on group rounds, so that's usually morning, you are just a silent observer unless they've told you that you can introduce the patient to the rest of the team. That is really important to know and goes back to asking the attending beforehand. In group rounds, where the attending goes, the resident, the medical student, and sometimes you have nursing there, sometimes you have other consults there. You've already presented the information that you've gathered. So it's best to start with just thinking, I'm silent, I'm listening. And again, it's part of the hidden curriculum because it seems a lot of times you feel like you need to be talking. Sometimes attendings want you to do that. They have you introduce the patient to the team or talk about the patient in front of the patient or explain what we talked about. But that goes back to lesson number 1. Ask expectations. What do the residents and attendings like? Do they want you to do that, or they want you to go into a corner and just zip and listen? And so that was specifically talking about if that's your patient. If it's not your patient, we already talked about this earlier, you can't say anything. And that is hard. I think it's one of the reasons it's so hard is because maybe if you have marginalized identities like myself as a Latina and a female, you feel like if you're not saying something, your silence maybe makes you feel like you don't know the answer. And being in this environment, you don't know the answer. And even if you do, this is not the environment where they want you to show that you know the answer. And it's hard because sometimes the attending asks the question and maybe will look at all of you. If they do address you specifically, sometimes they'll point you out, say something like that. But usually when an attending asks, the question is more directed to the specific med student or resident that is in charge of the patient. Ooh, that reminds me. This was really weird and confusing because I've never seen this before. It goes by rank. Sometimes when an attending asks a question, they will direct the question at the medical student. If the medical student doesn't know it or they say something, then they go up to the next person in rank order. So that would be the 4th year medical student if there's one. And then if they don't know it or they provide an answer, but the attending wants more information, then they'll go to intern, 2nd year, 3rd year, 4th year, fellow. That's usually it. But that was really weird the first time. And you know what? I remember the first time I saw that happen was in pediatrics inpatient, where they asked a question of me, and then they moved on. And I thought that meant that I got it wrong or that they thought that I wasn't smart enough. And that was really hard for me. And so, no, that's not the case. Just as you go up in the level, that's how the attending makes it a dialogue. It's actually something we're taught as residents. When you have a question, don't have one, a yes, no answer, and two, make it, there's actually a word for this. And so they will go from one person to the next to the next. It's actually part of the training and part of a good doctor or good resident and good teacher and educator to go up and make it harder and harder, to make it harder for each level of learners. So I hope that helps in regards to thinking or if asking why they keep moving around. It's not that you got it wrong, but that's okay. That's why you're here. Don't take it as you are not smart enough or good enough. Okay, now let's talk about lesson number 5. So, lesson 5, always finish your notes after roundings and before you leave for the day. So, this kind of goes back to number 1 about expectations. Sometimes they don't even want you or need you to write a note. If you don't need to write a note, why put in the effort to do that? Ask them what time they want you to have it done, because there are some places or some residents that do use your note, at least as information, what you gathered. And some places they're not allowed to do that. I remember I learned this lesson in my psychiatry rotation where unfortunately, I had an intern resident who got very upset with me and actually even wrote me up because I didn't submit the notes until the following morning. I had stayed till 7 o'clock at night. So, like, super long, calling the patient's mother, spending all this time writing a note, but I didn't think it was perfect or ready. And so I was like, oh, I'll finish it tomorrow morning. And she got very upset and even reported me to the M3 clinicals. And I got written up for it, for being unprofessional, for not turning in my notes on time. But there you go. I did not ask beforehand nor know what time she, my resident that I was working with, wanted me to have the notes in by. So all that hard work, I didn't even matter. Sometimes I need them early in the afternoon so the resident can use. Sometimes it's just before the nighttime, sometimes before 4 o'clock. If the resident maybe leaves at 4 o'clock and they have to addend them or at least read them, always important. So it's important, even if they don't have a preference, just get your notes in before you leave. And that will hopefully save you a headache and hopefully not get in trouble like me. You notice I do seem to get in trouble a lot. So it's all talking about why I talking about this, following the hidden curriculum. It's important to talk about. It's hard to be able to write notes in the time needed. And so one of the things that I found helpful is to, during the pre-round, start writing those notes. Already write in the notes for the new labs, write in if something happened overnight. So any pre-charting, just go ahead and put them in the note that you're going to write for the day, because 1, you're going to need it anyway, and 2, it helps you when you're presenting. If you forget where it is, it's already on the note. So hopefully that helps. One of the big things in M3 clinicals is they want you to have a plan. Even if it's wrong, it's important to show you have a plan. Ask the whoever's working with you at the end, what do you think how I did on presentation? How do you feel that I did on writing my notes or coming up with a plan? So being specific, that can also help the conversation go a lot better. And I noticed for me, when I come in with some knowledge of what the feedback's going to be about, it helps that stress and anxiety. Internally, my brain thinks, oh, they're judging me. But if I go in and be like, okay, I've told them I'm working on this thing, I'm asking for feedback on specifically this, that helps me maintain my emotions when it's not such a huge surprise. Now, obviously, it's not going to happen perfectly all the time, but it's all about practice. Lesson 6. Oh, this is another important one. These are all important, but all the lessons I've learned over the past years. Your only assigned job or role as a student, even if you're in the hospital or in the clinic, is to be a student. student. I know that seems weird. You would think, oh, I'm in the hospital. Now it's time to be a doctor or a pretend doctor or an almost doctor. No, it's be a student. What that means is they expect you to learn. So if you're not actively learning as in front of a patient or rounding or in a conference, you should be studying and make it obvious that you're studying. So you can have like your computer screen like facing towards the residents or have a physical book. It's weird and odd, especially for me, where I expected them to trust me. But unfortunately, that's not always the case because some students maybe do not do that. Maybe they are on Instagram or maybe they are shopping on Amazon, just to prevent them from thinking that you're not paying attention or wasting your time. Show that you're studying. Perfect opportunity to use those UWorld questions, focus on that specific clinical. If you're an OB-GYN, do UWorlds on OB-GYN. If you are family medicine, do family medicine. That's why you have UWorld. A lot of people, if they don't want to do UWorld maybe after, that's where those books that you can get, there's like clinical cases. I don't like doing books for questions, but a lot of people like clinical cases. You can have, let's see if I have it, like actual, let me go get that book. That way it makes more sense when I'm talking about. I just use this pocketed one because I was on addiction medicine. There's one for IM rotations. There's pretty much one for every single rotation. And there's even a psychiatry one, but it really helps that you can just look up like, oh, I have a patient on that's having substance use. And so I'm going to read, obviously that doesn't work for this one, but a specific disease, maybe alcohol use disorder. Okay, these are the types of labs I should draw. These are the medications I should think about. And so this is really helpful because it allows you to look up things quickly. And obviously that's also what up to date is for, to get the best. But it really helps in the sense of you can, while you're waiting to present, you can really quickly make sure you have all the ideas. One of the big things in M3 clinicals is they want you to have a plan. Even if it's wrong, it's important to show. And so that makes it really easy if you have one of these pocket notebooks. It's called pocket notebooks. Like I said, there's one for every single clinicals, and it helps you to be able to quickly look it up. Even though you can have your phone and pull up to date, especially when you're working with older attendings, they can become pretty annoyed and upset that you're pulling out your phone because maybe they assume you're texting and they're more okay with a book. So that's a great opportunity to pull up this, or if you have the physical first aid, if you like reading first aid, maybe you get a first aid book specifically on that rotation, or maybe put a tab mark to know for that specific rotation. Because we're talking about that when you're in the clinicals, if you're not writing the note, if you're not talking to the patient, if you're not doing something clinical related, your job is to be a student. And so I hope that is helpful. Okay, let's see what else. So other ones that I talked about on that blog post on M3 Clinicals. M3 Clinicals is a great time to use online med ed. Osmosis also has some clinical case study videos, but online med I like the best because it has specifically, you can go into internal medicine and see a video with specific types of disorders that you most commonly see in internal medicine. And the individual on online med ed goes through a really good way to break down that disease or that condition, labs, why the labs are important, disease. So hopefully that's helpful. And I'll put the link below to that if you want. I do have a 25% off because I really liked working with them, and that really helped me during my M3 and really M4 year too. I actually just got the intern version because I'm about to go on GMF, which is the general medical floor. So I haven't seen internal medicine information in a long time, so perfect opportunity to use that information. What else for you can do while being in M3 clinicals? We're talking about lesson number 6 for what other ways you can study. I guess one of the things I do want to mention is At the end, if you don't know the rotation, you do have an exam. So that's why questions are so useful to practice with, especially you can look at the previous video where I talk about doing step 1, and I provide some like really good question study strategies, especially if you have struggles taking tests. I know I did until I learned from various tutors and doing a lot of studying on how to take tests. It's not just how to take tests, but how to take medical school step 1, 2, 3, and also these clinical exams. Practice questions are so important, and it's helpful because you're studying at the same time. You're learning the information, especially by looking at the answer, reading if you got it wrong, why you got it wrong, why something specifically in that question is wrong, or why it's this is the order, not that. So hopefully that helps. Please go to the step 1 video for more information on how to take tests, because I think that is really helpful. Okay, going to lesson 7. All clinics and hospitals have multidisciplinary teams with predefined roles, tasks, and responsibilities. Even though it is important to know what other team members do, you are not allowed to assist them. This was really weird and confusing for me, especially since before medical school, I was a phlebotomist, and a lot of other people, they were, what other things? They were in the emergency room as like note taker, or what's it called? Before medical school, they did things. Maybe they were a nurse, maybe they were an EMT. There were so many other things, and this is really confusing when you're in medical school, because you would think it would be helpful to use your own experience as help. Maybe you would think that the residents and attendings would grade you better because, oh, you know how to draw blood, so helping draw blood. Maybe some residents would like it, not all of them. And again, talking about the professionalism word that they always use. And so this is part of the hidden curriculum of knowing that helping is not helpful. Weird. Helping is not helpful. And even though it might seem like you're helping by taking a blood draw or helping transport patients, it's not appreciated. That was painful for me because I thought going above and beyond in that sense would give me those 4s, those high grades in being clinical, but it's not the case. Now I'm, again, like a preface, the other rules and lessons. This was my experience in 2 different medical institutions, one at an academic center, one at a community hospital. And it's interesting, at the community hospital county, they did find it helpful and they liked it. I always got higher grades at the county hospital than I did at my university because they were more willing. They appreciated the help. They were not as strict on clinical roles, and really it was like all hands on deck. But from the university, when I did the university hospital, they did not appreciate it at all. Part of it was they didn't want to get sued. Part of it was because they pay people and they don't pay me, and so it's a liability if I get hurt or I hurt the patient. Overall, that's why I use this number 7 lesson of saying that even though it's nice, even though it seems like it would be helpful to follow the nurse to learn what they do or follow the physical therapist, as a clinical medical student, unfortunately, they don't see it as helpful or meaningful. So good to know. Let's go to lesson number 8. So if you do not get a certain information from the patient because of time constraints or simply because you just forgot, it's important to say, I don't know. And this is, I think, one of the most important lessons from M3, M4 clinicals that I gained, and that we as residents and attendings hope to impart on students, is that it's important to recognize your own intellectual limitations. And in the first couple of years of medical school, it's hard because you learn so much information and they teach you that if you don't know something, it means you're not smart enough, or you're not going to do well on step. But in the real world, in clinicals, that's the reality, is you're not going to know everything. And that's one of the amazing things about medicine, is that there is so much of every single patient is different. Every single diagnosis, it represents itself different. And it's really hard to say, I don't know. And that is something that I continue to practice as a resident. And it's important to practice saying that. One of the things I had a conversation with a attending about as a clinical student is the recognition when you forget to ask a certain question. It's better than just making it up, because when we start doing that of making up, even if it seems like it's small, oh, sure, I think they said this. If you start developing that negative or bad habit of kind of making it up or not being 100% of what they said, that's where things can be unhelpful and you can actually provide some harm. So it's better if an attending or resident asks you, did they go to the bathroom this morning? And if you say yes, and they hadn't, then maybe the attending won't ask them. And let's say they just had surgery and it's been 12 hours and you lied and said they did urinate, then we're not going to watch it, and that could lead to a complication or an infection. And so this was one of the lessons that is important for you to learn in clinicals. Just say, I don't know, instead of saying, I think it was this. Just said, I forgot to ask, something like that. Hopefully that makes sense. Lesson number 9. One must ask for feedback often and take it without emotional reaction. Okay, another story time. And this was this was the exact same resident that I was talking about, who I turned in my notes the following morning instead of the same day. I went up to her to ask for feedback on my notes, which is a good thing. You want to do that. You want to ask, because that's how we get better, is improving. But that's when she said she got upset with me for turning it late. It was like 2 years ago. So I don't even remember what she said or what her feedback was. But I remember I started just crying. And unfortunately, that specific individual, because of the turning in the notes late and then crying, that in combination is why she wrote me up for being unprofessional, because I didn't take feedback well. That story is a multi-thing of, yes, it's okay to cry, but it can be seen as not appreciating the feedback, not respecting the feedback. And so and this is hard, because taking feedback that's negative can lead to us, again, feeling not good enough, feeling like they're attacking us individually. But it's important to remember that the residents, attendings, whoever is giving you feedback, hopefully cares about you, cares about making you a better medical student, a better future doctor for the patients. Some ways that I try now when I'm asking for feedback from my attending, for my residents, it helps to remember for me to have a certain sentence, and that is, thank you for your feedback. That's it. Thank you. Thank you for your feedback. Even if I don't agree with it, or even if, because I've learned for myself, I can sometimes start to disagree or develop excuses. And those are the things you don't want to do. You don't want to excuse. This is just another individual's viewpoint of how you acted. They didn't see you for a long period of time, most likely. Like, they only had a short period of time where they have to evaluate you. And so just remember that it's not to attack you, hopefully, and they just want the best. And so if you're like me and have trouble taking feedback, practice no matter what they say, take a deep breath and say, thank you for the feedback. Now, if they are a good resident or attending, it will be more of a dialogue. If you're a resident or attending, to start a feedback session, I actually wrote an entire blog post on this, so I'll make sure to link that also below. Start with asking the medical student, what do you think? How did the rotation go for you? And this is helpful as a medical student or as a person getting the feedback, because you can show them what you know you struggle with and what you know you did well and not well. And so that makes it a little bit easier for then the person giving the feedback to be able to say, oh, I saw that too. Or actually, I don't think that you have problems with that. You did a really good job. Or, yeah, you're right. You struggle giving presentations. Let's practice together how to give presentations. So to make it more of a dialogue instead of it being a one-way conversation of feedback or emotion attacks. Like I said, it's not always, and it shouldn't be, but sometimes it can feel like that. And so hopefully that helps on a way to take feedback as a medical student, as a resident, or even as an attending. It's hard for everyone. So know that it will be okay. Going specifically more on what I wrote about in that blog post, don't make excuses. You should know from previous verbal and written feedback what you need to work on. So maybe it's helpful at the beginning of a conversation or at the beginning of a rotation. You can say, I have previously been told I struggle with giving presentations, or I struggle with staying on time, or I have noticed or I've been told I struggle with staying in order or only coming up with a couple differentials. So providing that feedback can help the person evaluating you to be able to focus in on it. Because I don't know if you've ever received feedback that seemed very general, or sometimes they said, read more, study more. That's the general feedback when you don't actually remember who the medical student or didn't actually really watch them. And so it is helpful because these grades and feedback are used in your MSPE, the thing that the school provides residencies to show how you are as clinicians. And so in order to have good informative feedback and notes on the MSPE is by showing that improvement, saying at the beginning, I'm working on this, actually work on it, and then ask whoever's working with you at the end, what do you think how I did on presentation? How do you feel that I did on writing my notes or coming up with a plan? So being specific, that can also help the conversation go a lot better. And I noticed for me, when I come in with some knowledge of what the feedback's going to be about, it helps that stress and anxiety in me of, I don't know, they can be judging, like internally my brain thinks, oh, they're judging me on everything, judging how I'm dressing, how I look, how all these things. But if I go in and be like, okay, I've told them I'm working on this thing, I'm asking for feedback on specifically this, that helps me maintain my emotions. Now, obviously it's not going to happen perfectly all the time, but it's all about practice. And when it's not such a huge surprise, that is emotionally helpful. To try to not be emotionally triggered, say, thank you for that feedback. I will work on XYZ, or I will work on it. One of the physicians said, getting feedback can be a double-edged sword. If you can't take it positively, it can demotivate you for a long time. And I agree with that. I think that is one of the challenges with feedback. If you take it personally, which is hard to not do, it can make you feel not good enough. It can make you feel like you shouldn't try as hard anymore if you're trying hard. Like, it can really impact you. So those are hopefully some strategies to prevent that from happening. Okay, we finally got to lesson number 10. You are not a doctor. You are a student, which means even if you think you know, you probably don't know yet. It goes back to being a student, studying for those step 1, step 2 exams. On the blog post, I went through a lot of my experiences, and I think I did that already. By when I went through every single lesson, I provide something that happened to me when I was at clinic. So hopefully that helps. But if you want more examples, go to that blog post that's called Navigating M3 Clinical Year, 10 Lessons Learned. Here's 10 rules, hidden curriculum rules for the M3 clinical year. And this is a summary. I'm going to be really direct to the point. Rule number 1, Connect with every attending and resident at the beginning of the week to discuss their specific expectations of you in regards to patient conversations, physical exam, and extra support to the team. Rule number 2, always ask and confirm permission to do anything, even talk with the patient. Rule number 3, only ask OPQRST questions on one main problem or procedure they are presenting for, and the expected questions that the resident has asked you to inquire about. And if your school doesn't do the OPQRST, that's just a way to remember onset, provocation, quality, radiation, severity, and time. If you didn't go over that in your medical school, or you have another, I've heard other medical students say it a different way for other schools, but really focus on one main problem because you only have limited time. Okay. Rule number 4, prioritize listening and observing in clinical setting. 5, only answer the specific question that is asked. I'm going to go a little bit on tangent here. I learned this in my OB-GYN clinical rotation. An amazing attending recommended this because they noticed that I would start talking. I answered the question, I would keep going. I was talking out loud and I was saying, I was explaining my thought process, which I thought was helpful because that's how, when I'm doing questions on an exam or when I'm writing up the note, I walk through my thought process. But not all the times the attendings like that, especially when we're talking about surgeons. So surgery, OB-GYN, urology, ENT, they like short, sweet answer. And the reason they don't like, the reason it's sometimes detrimental to keep talking is sometimes you maybe said the correct answer, but then while you're talking and keep talking, you can actually say the wrong thing, and then they focus on the wrong that you said. This was a recommendation from an attending that I had. They said, just answer the specific question asked. Rule number 6, study when not with a patient and provider. Rule number 7, spend 5 minutes for short visits, about 10 minutes for the long visits in the clinic. Have it on a timer or watch. 8, no counseling, educating patient, or phrasing that of what they can expect talked about with the MD, which is confusing because in the OSCE, at least at our school, they said it was important. At the end of the OSCE, they recommended us like, and we're going to come back with the attending and we're most likely going to do an MRI. We're most likely going to do a blood draw. But then when I was doing that in real life, a lot of the attendings did not like that because sometimes it wasn't true, and that can make the patient upset because it's like, oh, that med student told me we're getting a blood draw and then we didn't. So just in case side of things, just say, I'll be back with my attending, or I'll be back with my resident. Try not to say specifically what the plan is, even if you know, even if you say, oh, we might do this. From my experience, it is more detrimental to say that. Number 9, when a patient is super confusing, just say that. Say, I don't know, I was confused. That patient was confusing. It seems to be an okay like verbiage for some residents because that can happen more times than you think, that a patient talks a lot or says a lot of things and it's just confusing, or they go up on tangents, and it's okay to say, it was confusing, this is what I got, and this is what I remember, or this is what I got from that conversation. It's okay. We get it. As residents have been there and talked to patients. There are patients that it's just confusing. A lot happened. Maybe they have a very complex past medical history with a lot of surgery, different healthcare conditions, and that's okay. That's part of why you're here in medical school, is to learn and to practice. Rule number 10, clearly say, I don't know, or I'm sorry, I forgot to ask, when you don't know a question. So hopefully that was a good summary. Added a couple things that we talked about before earlier. Let me know if you have any other questions for M3 clinicals. Thank you so much for listening. Today we talked about the 3 and M4 clinical year and different lessons I learned. I'm currently a psychiatry resident, these are some lessons I learned that I hope now, after I've been in the clinical environment and as a resident mentoring other medical students, I hope these lessons have helped, because it's hard being a clinical student. You were studying in the books, studying for step one, and then now studying your clinicals, and it's hard to know where your role is. Today we talked about a specific blog post, so I'll have that blog post linked so you can get more information. If you like these videos, subscribe. I also have other videos about medical school, dealing with failure, with finances, imposter syndrome. So I hope those videos and blog posts help you. That's on medpsychmoss.com. If you want to get in contact, you can follow me on all social medias. Thank you for listening to my life, both as a patient and a doctor.